All right, so IV fluids. So how do you give fluids? When should they be given, and when should they be discontinued? So we have this protocol here, which is developed in Britain, right? So Great Britain has these nice guidelines, which are the National Institute of Care and Efficacy. I have no idea, but these are guidelines. They finally laid the stamp down and said, you know what, there's too many people getting poor outcomes with excessive fluid. Let's go ahead and say how much fluid someone should be getting, right? So it can be separated into three different parts. We got resuscitation fluids. Obviously, if someone is dying in front of you, they may need fluids, right? So, and there's a lot of good evidence that in the first 6 hours or so of resuscitation of fluids, you should be giving. That's going to reduce organ dysfunction, right? And that's the first like minutes to hours. But after that, we need to start getting this fluid balance down back to baseline, back down to zero at least, or net even. And as we'll kind of find out, there's a lot more mortality if we don't. So the idea is to get that the fluids under control. But if they are shocky, right, you use your A, B, C, D, E's. All right, patient may need fluid resuscitation if the BP is less than 100, if the cap refill is poor, they're cold to the touch, respirates up, the NUSE or the MUSE score, which is used out on tele to identify patients at high risk for decompensation. If someone is in shock, they need to get shock fixed. They need to get fluids usually, right? If they are hemorrhaging, obviously we're gonna give blood first, right? But we got to figure usually giving fluids is the go-to, right? So the sepsis guidelines usually at 30 mLs per kilo, and I'm kind of find out, not like 4 liters, right? If they weigh 160 kilos, right, we're not gonna give that much fluid. It's per the ideal body weight. That is what we should be looking at, okay? But if they give more than 2 liters, then you're done, right? It's not, after that, you got to consider other reasons, right? Look at the patient history, look to see if there's anything else we can do to fix them. If they still need fluids, they still have a burn victim, we use the Parkland formula and such. But if they have they were like in post-op in the OR for 8 hours with an open abdomen, yeah, they're high risk of fluid deficit. We can initially resuscitate them up to a MAP of 65, systolic of 100, so they don't have the shocky symptoms that we assessed up top. But once you got them recovered, then you do maintenance fluids, right? So maintenance fluids are just to maintain their fluid balance. And usually these are good for about 2 to 3 days, right? Usually you're not more than 2 days of maintenance fluids, right? Unless they're super sick, I can't think of a good reason why you would have this much fluid being infused to a patient, right? We'll talk about how much it should be, right? Everybody needs about 25 to 30 mLs per kilo per day. You need that much water to actually survive, right? You need water, it's usually about 20 mLs per kilo, right? So 100 kilos, about 2 liters, right? You need to survive for metabolic processes and for things to work in the body, right? But after that, it's just way too much. And I come to find out there's a lot of reasons where fluid can come from, right? Just like your normal saline pushes, your piggybacks, your enteral feeding, which is also something that should be done as soon as possible, right? We do it within 12, I think 12 hours is our protocol. Within 12 hours, we get someone on tube feeding, just choose something, right? We get trickle feeds going, 25% of the caloric needs, and we just kind of increase that with, with dietary nutrition services input, right? And tube feeding contributes to volume, right? So once someone is fixed initially, we need to start tube feeding as soon as possible. And we've talked about reasons for MPO and reasons for not MPO. And usually we err on the side where let's just try it. Let's see what happens, right? And if they develop an ileus, then we'll go back to considering other options, right? And there are unique situations where they have like severe dehydration. They have severe urinary losses like post-AKI polyuria. With all that BUN that's been built up over time, they're recovering. Now the BUN is osmotically active. It's going to pull all the fluid with it. So yes, we do have to restore a lot more volume for those patients. Those would be one of the reasons why we extend it beyond 2 to 3 days, right? But usually that's like the first 2 days that you're really looking at that. All right, there's other complex reasons why you might need fluids, but again, most times in the ICU even, they've done a lot of research. It's by day 4, you should be even, right, with your fluid balance. So they came in, they gave 3 liters, that means you need to get 3 liters off by day 4, okay? So as we give these maintenance fluids and as we give these these routine fluids and as we give these resuscitative fluids, whether it be LR or abnormal saline, doesn't matter what you choose. If you choose fluids, balance of crystalloids or normal saline, you can see just a baseline, a 70-kilogram man who is normal, healthy, right? They went to the lab and they gave this guy normal saline, got this guy LR, got this person isotonic crystalloids. What happens is 82% of it will leak out of the vasculature and will leak into the interstitial spaces. So you can see here's 1 liter, all right? 1 liter, here's the interstitial spaces, here's the plasma volume. That's your vascular spaces right there. How much went in there? 180 cc's, right? What the other 870, 820, that all went into the interstitial spaces. So what actually went into the cells to actually feed the cells? Well, crystalloids don't do that, right? Crystalloids don't give volume to the cells, right? They give volume to the vasculature, and they also, the excess volume will then go into the interstitial spaces. And the cells will then decide if they want to partake in what those nutrients have or don't have, right? D5 water, though, as we know, is going to be metabolized immediately, and that water is just free water, and that's going to then, hydrate our cells with someone with dehydration. All right, so the choice of fluid matters, and we talked a lot about the choice of fluids, whether it be LR, NS, isotonic bicarb, Plasma-Lyte, or blood products. What do blood products do? They're just straight up right there into the vasculature. They are going to restore someone in hemorrhagic shock. They're great for hemorrhagic shock, not for other reasons. So resuscitation fluids. So what are we going to give for these? When do we give these? What are we assessing? We need to assess, are they MUSE positive, right? What is MUSE or NEWS? If you're, I don't think that's British, but it comes from it. But Britain does use the NEWS score, but they're pretty much the same. Basically, you're looking at vital signs and you're looking at SIRS criteria. So you got SIRS criteria, you got a heart rate elevation, you got a respiratory elevation, you have a temperature elevation, you got a white count change. This isn't really look at white counts, but you look at those SIRS changes, you look at vital signs, which includes your, it kind of overlaps a little bit, right, with your respiratory, heart rate, temperature, etc. But what it also looks at is like your O2 saturations. How much O2 sats? All right, that's not a SIRS criteria, but that's a vital sign that we assess. And then another thing they look at is altered. Are they altered or not? Do they have abnormal mentation of any sort? These are well-researched criteria that they found out these patients have high mortality, therefore you should intervene early, right? When the MUSE score is greater than 5, that's usually a sign that you have a sick patient on your hands. That's why on like the telemetry floor, the charge is to look at the MUSE score for all their patients, and it's a quick a dumb thing that the Cerner system can do, the EMR can do, and calculate based on the last LOC, right? Did they chart their alert or did they chart lethargic? They chart lethargic, shoot, right? They're going to get a worse score, right? They're going to get a higher score. They chart a heart rate that's greater than 100, they're going to get a worse score. Greater than 120, even worse, right? So you can see the temperature, 35 to 36 gets a bad score because remember, low temp is just as bad as high temp, right? You got a temperature greater than 39.1, that's 2 points right there. So the more points, the higher risk they are, right? So we're looking at how sick are they, right? So MUSE score or NEWS score is 1. SNS symptoms is kind of combined with that. Also, your SNS symptoms fire off when you have low blood pressure, you have hypoxic state, a septic state, and sometimes you need that. You can carry that over not only for the NEWS score or MUSE score, you can also carry it over with the shock index, right? So the shock index we talked about in shock, ironically, and that's your heart rate divided by your SBP, right? So you take your heart rate of 100, systolic blood pressure of 100, right? So someone's heart rate's 100 and their blood pressure is 100. That's not great. That's someone that's a little bit sick, right? So that's 100 over 100, that's 1, okay? So a shock index of 1 right here is moderate shock already. You can see a moderate shock down here. If they were like hemorrhagic shock, they would be already require about 9 units of blood, right? If that was their kind of where they're at, that's on average. But if they have a significant trauma, but as your blood pressure goes down to 80, what's going to happen to your number? Get bigger or smaller? The top number goes down. Get a bigger number, right? So we're going to have a, sorry, I messed up. So the systolic blood pressure goes down, right? So it's going down from, instead of divided by 100, it's divided by 80. That's a bigger number, right? Your heart rate then goes up to like 120. So it's like 120 and the systolic blood pressure is 70. So that number is going higher and higher and higher, and that shock is getting worse, right? So that's a thing that we can look at for, does someone need to get stat fluid resuscitation? Okay. Another things we look at are they getting hypovolemic for some reason? Okay. So hypovolemic, they have signs of dehydration. Are their fluid balance on their eyes and nose getting negative? Are they losing weight, right? Are there a lot of GI output via the JP drains or via the NG tube or the ostomy? Is there a lot of blood loss, right? Is there a reason for a lot of your urine output and someone has like polyuric, for instance? That patient needs more fluids. Do they need to be resuscitated? Probably not. They probably just need routine maintenance. But it can get to the point where it starts causing a huge vital sign derangement because someone wasn't paying attention and the MUSE score gets worse and worse and worse. That's the idea. The EMR will fire off, hey, your MUSE score is high, and you got to investigate why that was. It could fire off erroneously, so they were just in pain. Right? I'm in pain, my heart rate's up, my respirator rate's up, right? And if I'm like, if I'm really like working up after PT, right, that's going to cause my temperature to be up a little bit. So I'm already like a MUSE score of 4, right? If I was really painful, it could be like MUSE score of 5 with all that, heart rate greater than what? Was greater than 2, well, that's blood pressure. Heart rate greater than, where are we at here? Pulse greater than 130. That's already 3 points right there, right? So you're already, that can skew our score a little bit. So we got to use some critical thinking. So the computer and AI can only do so much. We have to use our eyes to assess the situation. Okay, so if they're fluid responsive, right, how do we are going to give some fluids to see if it works or not, right? So we can do a passive leg raise. That's been validated. We talked about that in hypovolemic shock. That's something that they've done research on. They said this works. If they respond to fluid by raising the legs up 90 degrees and with a flat supine patient, then that's something you can give a little more fluid to. That might work, okay? Do we need pressors though? So sometimes their eyes and nose are like positive 4 liters. Giving 250 mLs is not going to help the situation. It's just time to start pressors now. If someone's able to take PO, we should give them PO fluids. That makes sense, right? But we have to look at, are they taking an adequate amount of PO intake? Because if they're not, that can then cause a hypovolemia and then lead to need for maintenance fluid, right? Will it lead to fluid resuscitation if it's ongoing? Maybe at home, right? They were dehydrated, they have a heat stroke, their AC cut off. That could then lead to a hypovolemic shock and lead to someone that is super, super shocky, has a high MUSE score, has poor cardiac output, has a poor assessment findings. So that's the idea. When we're assessing them, do they need fluids now or do they just need maintenance fluids? So a shocky patient. So this patient needs fluids now, right? They have signs of hypovolemic shock, and we looked and saw that they have SNS symptoms of cool, clammy extremities. They were syncopal, altered. We did a little ultrasound, and we saw they had decreased filling volumes on their POCUS of the heart, right? So these are patients that need to get fluid resuscitation. Giving 500 cc's is good, right? That can tell us if they're going to respond or not to more fluids, or do we need to step in and give vasopressors, right? But giving 250 is easy as just raising the legs up. That's what a passive leg raise test can do. All right, just passive leg raise can just be a little quick 250 bolus in of itself to restore the blood pressure, and then give another 250 because you can't get the legs up in the air the whole time, right? So giving a little more fluid to then check to see was there a good response or not, right? There will be a somewhat response over time, but after a while there won't be a response. Will there be a raise in blood pressure if I give 500 cc's? Every patient will get a rise of blood pressure, but is that good for every patient? No, there's a danger of excessive fluid volume, right? Because what happens is, like, let's say the eyes and nose are positive 8 liters, right? And someone says, oh, blood pressure's low, and they call the provider says, oh, give 250 cc's of volume, right? Fluid bolus given, and blood pressure goes up, and then the fluid 82% leaks, right? And then 82% leaked, and now the blood pressure is low again. And then now it's the next shift, new provider, new nurse calls, hey, blood pressure's low, let's give 250. And then it happens again and again and again. Provider shift to shift, and then eventually they're positive 8 liters, positive 10 liters, positive 12 liters, and that's going to lead to more complications down the road, as we've pointed out before, and we'll touch base again on the consequences of hypervolemia. Okay, so really the limit is 2 liters. That is kind of where the line in the sand should be. Can you do 2.5, 3 liters? Maybe, but 2 liters is really where we should stop, right? Seek expert help, right? That is where you should say, give it more 250, maybe, right? They can do a little more investigations. Oh, actually, how much diarrhea do they have? They have C. diff. They got, they got 2 liters out overnight. Yeah, let's give another 500 cc's, right? But after a while, it might be it might be worst case scenario. They might have a lactic acid that's brewing. They might have a sepsis that's taking hold, and they might have ketoacidosis that's developing. They might have hyperkalemia. So these are all the things we talked about that were causing hagmas, right? Things that will kill you that we have to assess. So instead of just giving 250 up to 250 bolus, it's better to do labs to assess what else could be going on that's causing them to be hypotensive, right? So if they do have surge criteria, our tradition we give it 30 per kilo, but antibiotics will help. And if they're hemorrhaging, what's the best thing for hemorrhage? Bloods, right? To give a blood transfusion will be this thing for someone who is losing actual blood, right? And they might need an MTP. The only difference between MTP and blood is someone has a systolic blood pressure less than 90. That's the only difference, right? If you actually are fluid negative, they got a burn victim, you have excessive GI losses like we mentioned, they got excessive dehydration, then yes, maybe you can give a little more volume, right? Such as like a DKA patient, those patients lose a whole bunch of volume. HGS patient loses a lot of volume. So those patients do need a good amount to like 4 liters, 5 liters sometimes, right? All right, the idea is to not over-resuscitate, right? You don't keep giving fluid until they're no longer fluid responsive. So oftentimes that'll happen is we'll give fluids and fluids and fluids and the blood pressure is still low. And it's like, well, that's too late. We should have started pressors earlier, right? If you start pressors then that causes worse outcomes because now you're gonna be behind the 8 ball trying to get their blood pressure back where it needs to be. Right? There is something fancy thing we can do with pulse pressure variance, right? But they have to have like 3 criteria. They have to be like on assist control. They have to have like a set tidal volume, like 10 per kilo. They have to have no open chest. All these things, they meet criteria. Then the research that says doing a pulse pressure variance, which our monitor does based on the A-line, it will tell you if someone is fluid responsive or not, or is dehydrated or not, right? So we talked about this when we talked about A-lines and hemodynamics, but your A-line will change. This little percentage change right here is because our heart is behind on the volume, right? So the heart it gets squeezed from all the lungs, from the positive pressure from the ventilator, pushes all the fluid from the lungs into the left side of the heart, and the left heart pumps the blood out, right? And the left heart's like, okay, ready for the next go around, but the right heart is in debt. It's like it can't keep up with the volume status, right? So that's a sign of dehydration or low volume when you have a wide pulse pressure variance. Okay, so hypovolemia leads to problems, and hypervolemia leads to a lot of problems. You can see impaired oxygenation. We talked about at the outset, just the distance between O2 and the tissue over here, that can increase with more fluid, right? So it's more distance for O2 to travel just on its own, right? You got hypertension, that causes problems. Edema, all the fluid you're giving is going to have to go somewhere. We know 82% of it just leaks on its own, and all the extra volume is not going to help out the kidneys. It's not going to help out the heart. It's not going to help out in many things, especially the abdomen if they have an abdominal process, right? So organ dysfunction, organ congestion happens. Wound healing is not great when all the wound is full of fluid, right? It's very, very friable. It can't be connected well. So it just doesn't make sense to give too much volume. All right, so you can see here fluid bolus given, right? So did we actually improve cardiac output with giving fluids? Maybe a little bit, right? But if they did you actually improve the delivery of oxygen? More fluid is not going to improve delivery of oxygen, right? Our DO2 formula didn't have fluid content in it. It was, how much hemoglobin they have, how much PO2, how much, I said hemoglobin, right? And how much PO2 and cardiac output there is, right? What else? VO2. In someone in sepsis, a septic shock, they don't utilize oxygen because the inflammatory mediators are going to inhibit oxygen utilization. So you're not going to improve VO2 with someone that has a sepsis process, right? So you got hemodynamic improvement is sustained more than 1 to 2 hours because it's only going to last that fluid for about 2 hours tops, and then all of it's going to dissipate 100% or 82% into the periphery. If they have sepsis, how much is it now? It's 95% or more of the fluid will then leak because now you're inflammatory and you're leaking more fluid into the periphery. Okay, if there's a benefit, it sustains, then yeah, great, fluids worked, right? That's why 2 liters was our limit. So maintenance fluids. So maintenance fluids, this is after someone's been resuscitated and now they need maintenance fluids because they have someone that has like obvious dehydration of some sort, right? They need to get fluids for the next 2 days or so. These should not be continued for more than 2 or 3 days, right? If they're able to take per os, it's good to saline lock them. So it's okay to, they can take PO. They don't need maintenance fluids anymore, right? You're getting reported a patient's been here for 5 days. They got LR at 75 or have a mid NS at 100 or something. Then that's going to cause, that's a huge, red flag. It's like, what are we doing here, right? They're getting tube feed. Tube feed is a significant source of fluid, okay? So, but if they do need fluid in their first 0 to 2 days, then there's this 4-2-1 rule that we get from PEDS, all right, where they give 4 mLs for the first 10 kilos, they give 2 mLs for the next 10, they give 1 for every kilo after that. So basically the first 20 kilos, right, is 60 mLs an hour. And then after that, you're going to add 1 mL per kilo for whatever their weight is. So if they weigh 70 kilos, a regular sized human, right, that's going to be about 110. So 20, right, to 70, that's 50, right? So 50 plus 20 is, 60 is going to be our first 20. And then the next difference, right, which is 50, right, is 1 ml per kilo. So 60 plus 50 is 110 mLs per hour. Okay, but every person needs about 20 mLs per kilo per day, maybe 25 is on average, right? But no greater than 30, right? So 30 mLs per kilo, never more. That's not an appropriate amount for a patient. If they're obese, right, then you might have to then use ideal body weight. Like the ideal body weight of 5'11" male is about 70 kilos, right? So that makes sense, right? So 60 mLs per hour plus 1 kilo for every kilo greater than 20. Right, so as we mentioned, a 70 kilo patient, right? For the first 20 was 60, and the next 50 are 1, right? So that's 110. But otherwise, if they're obese, right, that's where we then use our ideal body weight, right? Rarely does a patient need more than 125 mLs per hour, right? That's usually not or greater than 3 liters per day. That's usually that's a lot of volume, okay? You imagine if you're 100 kilos, right? 30 per kilo is 3 liters. So you shouldn't need more than 3 liters per day to operate off of. Okay. So if they are fluid overload though, we're going to reduce that from 25 to 30 down to about 20 mLs per kilo. We can't really go less than 20 because that's going to start causing more problems than good. So that's for the fluid restriction, right? What are the usual fluid restrictions? About 2 liters, right? Maybe all the way down to 1.2 liters because we know they're going to there's other sources of a volume, right? Because the 1.2 liters is what nursing gives, and the other 800 cc's is what dietary gives, right? So 2 liters per day after 100 kilos is how much a person with fluid restriction would get, right? Otherwise, we go up to like 3 liters, 3.2 liters maybe for our regular patients. But as we're getting this fluid resuscitation, we're going to be alert for any kind of hypervolemia, any kind of hypovolemia. Do they need to get more volume or not? So that's the idea with fluid rates, right? Usually what's going to get you by is 75 mLs an hour. Gets you by for most patients, okay? But even like a fluid restriction patient, 70 mLs per hour is on the low end, right? Just 1 ml per kilo approximately versus our little pediatric formula for a regular patient, okay? So for a fluid restriction patient, it's just 1 ml per kilo is usually a goal fluid rate if they need fluids. Okay, we're observant for hypervolemia, which is very common in our CKD, our CHF, our renal patients. Okay, and then electrolytes. So what are some electrolyte goals? So sodium, potassium, about 1-ish, right? So approximately 1 per kilo per day is how much sodium someone should get and how much potassium someone should get. So someone is 70 kilos should get about 70 of potassium per day, right? So someone's MPO is like, oh, I can't believe I'm giving 80 MEQs of potassium today. It's because that's how much they need for body processes. Okay, what else? So glucose, you need glucose throughout the day, otherwise you're going to go into ketosis or starvation, and that's not going to help someone out who's already acidotic in the ICU. So someone's NPO, they need dextrose of some sort. Basically, after you've resuscitated them, then dextrose will be utilized. And what's even better is if we're going to start early tube feeding, right? So tube feeding is going to be our goal. And once tube feed is started, then we no longer need fluids anymore, right? Now we are giving tube feeding, and tube feeding will contribute to volume overload if we're not careful. You shouldn't have both going. It's either one or the other. If the tube feeding's at 10 mLs an hour, yeah, we gotta make that up eventually, right? But the tube feeding's going at 60 mLs an hour. Well, 60 mLs is almost 70, right? And do you think I'm going to make up that 10 mLs an hour with piggybacks and drips and other things? Yes, that's going to be made up. So, and heavy flushes and all other fun stuff, right? So just having, a tube feeding is enough reason to not continue maintenance fluids. Okay, so in the first 6 hours, first 4 hours, that's where we resuscitate someone. That's the R here. We'll resuscitate them with volume. Their sepsis, we got 30 mLs per kilo is usually our target, but usually remember it's like 2 liters is tops, right? And then after the first 2 to 3 days, that's where we may resuscitate the fluids, and then once disease process corrects, then it's time to get them back down to even, right? That is our goal afterwards. Otherwise, there is bad outcomes if we don't get them back down to E for evacuating all this volume that they're building up over time causes all these hypervolemic complications, multi-organ failure, right? So altered immobilization is going to be prominent with someone that is full of edematous fluid, right? They can't mobilize, you can't get to the ICU, you can't get off the ventilator, you get delirium. There's all kinds of problems that will develop if we have hypervolemia. At the same time, we have hypovolemia. That causes problems too. So the sweet spot is right here in the middle. That's where we have them right in the middle. We get them optimized. Once they're optimized and fixed, then we prevent hypovolemia and we prevent hypervolemia. Because when we're optimizing them, we can even get below the line. So that could be a problem too. So it's always about their fluid balance, right? And fluid balance is not always accurate, unfortunately. But what is accurate is daily weights. Daily weights are not going to lie.